And today we're speaking with Dr. Bridget McCandless. Dr. McCandless is a Kansas City-based internist and a long-term member of the chapter. She's been particularly strong in public health advocacy and medical care for the underserved. Thank you for speaking with us, Dr. McCandless.
Happy to be here.
So let me start by asking a little bit about your early life. Where were you born and where did you grow up?
I was born in Salt Lake City in Utah because my dad was doing his PhD work at University of Utah with Dr. Goodman, who wrote Goodman and Gilman. And so we lived there in student housing, and an interesting world since we were a Catholic family in a Mormon town. That led to some interesting experiences, but I think also broadened my parents' perspective on different religions. And then from there, my dad did his PhD work at McGill in Montreal. So we moved to Montreal and we were an all English speaking family. My parents enrolled me in preschool because they thought I was a bright kid and needed the opportunity for that. And soon started getting letters home from the teachers saying, you know, your daughter is socially challenged. She really has very few verbal skills. She's got real problems. We think she needs to be tested. At which point my parents finally figure out I'm in an all French school. And once they moved me somewhere where I can understand the language, I got a lot brighter. So that was a early and important intervention. And then from there, we moved to Kingston, Ontario, where my dad taught at Queen's University, and then eventually made it to Independence, Missouri. And so I have been in Independence, Missouri for the rest of my life, and hope to stay here because this is my hometown.
So that's very interesting. I'd like to explore the issue of Salt Lake City just a bit more. You know, certainly when you were there, it was the vast majority of the inhabitants were Mormon, as you said. I had friends that were there in the medical community, and the experience of the doctor half of the marriage was quite different from the non-doctor halves in general, in that the influence of religion in the medical center and the university was much less than it was in the community. Was that your parents' experience as well?
You know, I was a little kid, so I don't remember much of that. Our discussions about Salt Lake were more about, you know, there's one Catholic hospital in town, and I was born on September 8th, which is the birthday of the Virgin Mary, according to the Catholic Church. And the nuns had told my parents I would not be released from the hospital until I was named Mary, with no exceptions. So eventually they agreed to give my middle name as Marie, and we made our escape from the hospital. So I'm still thinking there was quite a bit of religious influence on the hospital at the time.
Oh my, that's quite a story. Was your family from Canada originally? I take it not, but your father's first few career stops were there, I guess.
Yeah, my dad was from a very tiny town in Montana, where everybody knew everybody's business. And my mom was from Omaha, and they had met at Creighton University in Omaha, where my parents were both studying. And then from there went to Salt Lake because it was such a good place to study pharmacology. And then from there, sure, Dad got his post-op work, his postdoc studies were all done at McGill because that was what he was interested in.
Interesting. What did he do when you came to Independence?
My dad taught at the Osteopathic Medical School here in Kansas City, and he taught there for 35 years. When I counted up the students, when I was getting ready for his obituary, my dad had educated more than 15,000 medical students in his long career. So he had quite quite the fingerprints on the house of medicine.
Yeah, yeah. Did your mother work outside the home?
My mom was an orthopedic nurse, so we discussed all of the gory things at the kitchen table, and that was my early introduction to medicine. My other two sisters were relatively horrified by the topics of discussion, but I loved them. So, you know, you follow in the footsteps you're given.
Is that what influenced you to become a physician?
And one of those formative experiences, my mom sent me to work with my dad one morning because at his university, they had swim classes for little kids. So he took me to the lab with him, and I went to swim lessons and then came back to my dad's lab. And he let me dissect some very large lab rats that he was working on. And when I came home for dinner in my 5-year-old self, my mom said, "Tell me what you did today." And I said, "I put a rat's brain in a centrifuge." And I was clearly very pleased with the process. And I'm not sure if my mom thought she was raising a future doctor or perhaps a serial killer, but the rest is history. And I was hooked on science from that minute forward. And really by 5th grade, I knew I was on the straight line path to medical school, which is such a gift to know where you're going. I didn't know what kind of medicine, but I knew that was the path that was going to make sense for me until about high school. And I had a really influential political science and history teacher. And I came home and I told my dad, I'm like, I'm rethinking this medicine thing. And I think maybe I'm going to go into politics. And my father looked at me with a straight face and he said, "I raised you better than that." So that was the end of the political sphere, and moved back into the medicine side of the world. But I think the joke was on him because I ended up loving politics and public policy, and that led to my future.
Yeah, yeah. Well, what was your path forward then? Where did you go, and how did you prepare for medical school?
I went to University of Missouri in Columbia, go Mizzou, and really just was very fortunate to pick good classes. It never occurred to me that there would be an advisor for someone who went to medical school. So I just kind of blundered my way through, and right at the very end of school, met the med school advisor, who was horrified that I had not come to see him. He still looked at my transcript, and I had done okay figuring it out on my own. And he wrote me a very nice letter. And then, as the world comes full circle, when I was in my clerkship, I ended up taking care of him as a patient. And so he, at that point, I think, was very happy I had made it into medical school with his glowing recommendation. So,
well, what years were you in medical school?
I was in med school from 88 to 92. I think that's right. Yes, 88 to 92. And then from there, I went to University of Virginia in Charlottesville for my internal medicine residency. And I really went only planning to be there a year and then apply for dermatology. It didn't end up that way. I was on my dermatology rotation, and my professor, who I adored, he pulled me out of the room and he was like, "You are going to be such a good physician, and you're going to be such a terrible dermatologist because you keep talking to these people and asking them irrelevant questions about their medicines and their family and their illnesses." He's like, "I am on a 6 to 10 minute turn, so speed it up." So I think that was my clue that maybe internal medicine, where you got to talk to people and be engaged in their lives, was going to be a better fit for me than turn and burn dermatology.
Yeah. So I talked to Vicki Frazier several days ago, and she was a little earlier than you in medical school, and she told me that at Mizzou at the time, which is in the late 70s and early 80s. About 25% of her class were women. What was the percentage in your class? Do you recall?
I think it was north of that. We certainly hadn't crossed 50% women by that point, but it was a good mix. And it was also a good mix of rural and urban, which I really appreciated because that was an experience I didn't have growing up. And it would have never occurred to me to practice in a small town. And yet I had colleagues for whom they couldn't wait to get back to their small town. So that was a good education for me.
Yeah. You might be interested at some point to listen to Warren Lovinger's interview. His basic whole career goal was to train the best he could and then come back and practice in a small town in the middle of the country.
Yep.
And then went through this long process of deciding which town that was going to be. Went out and interviewed at different towns while he and his wife decided. So tell me a little bit what medical school was like at Mizzou in the late 80s. Were you as a clerk, were you still required to do much of the day-to-day work, including doing urinalyses and blood smears and EKGs and drawing blood and that sort of thing?
I think that transition was already underway. We did a little bit of drawing blood and starting IVs more as education than as an extender of the medical team. You ran specimens, you picked things up, you did all the stuff that needed to get done. It's interesting that when I went to my residency, it was a really, really heavy infectious disease institute. And so there was not a specimen that you did not gram stain, pretty much from sweat to urine to blood to anything that came off a body. So I probably could have had my lab degree at the end of training there. But at Mizzou, I don't remember having to be so much part of the extension of the workings of the hospital.
What was your tuition? Do you recall?
Yeah, I was trying to think about that. I think my tuition was $3,500, which, there's not a med student alive who wouldn't blush thinking about the joy of paying that little for school at this point. But I think that's a shockingly low amount of money. It was, of course, staggeringly high for me at the time because I was paying for my own medical school and trying to think about the financing of that. But in retrospect, to get out of school with so little debt, I don't think I recognized at the time what a phenomenal gift that was to me. But I graduated school with only $30,000 in debt, and man, what a lucky person I was.
I'm curious to know, did you work outside? Did you work at a side job while you were in school?
In college, yes, but not in medical school. I realized I was all in for medical school. That people who worked and people who had kids, I actually always felt bad for them because that split loyalty would have really been hard. Now they had the joy of having their children welcome them home at the end of a day, but I was pretty driven to be all in school.
What made you choose? What made you choose Virginia? I'm curious to go and uproot yourself from the Midwest, where you say you have deep roots, and then go to Charlottesville, which is quite different.
I wanted to be somewhere else. I figured I'd come home at some point, so this was my opportunity to go live somewhere else. And as I said, growing up in Montreal, we specialized in snow. So I had really already experienced that, and I wanted no more part of it. So that pretty much cut the top half of the country off. And so I really looked primarily at the Southeast. And I had a professor who highly recommended UVA. I had already done all of my interviews, and he said, "Oh, you skipped an important school. You need to go back." And so I went back there and looked, and the style of the school had me hooked immediately. It was very, very academic, but also very collegial. And at some of the schools in the South, I won't name them, but there were real physicians, and then there were female physicians. And I thought, no chance. I'm not coming here. So UVA fit me perfectly. It was small enough and yet drew from the whole country. And my gosh, what a smart bunch of people I went to school with. So we taught each other as much as the professors did. And it was just a good place for me.
Was Ed Hook the chair when you were there?
Actually, he was just leaving. Mike Sheld was the department chair. And wow, the thing is, you go to school with people and they're just the people you see every day. And then you realize, wow, we had some Nobel scientists here who came and gave us our lecture on H. pylori. And, when I had somebody with meningitis and I pop open my ID book and I'm like, wait, my teacher wrote this chapter. It just, I think, reinforced that I got to train with some pretty exceptional people.
So what was residency like socially? Was it, you alluded to the fact that some institutions were less welcoming to women, and I gather by extension that was not true for UVA. What was it like being a doctor there? What was it like to, live not just inside, but outside the medical center as well?
Sure. We were on every third call. We were at the hospital a lot. The fact that people decorated the rooms where we slept was kind of a bad sign, because you spent more time there than you did anywhere else. But we had a lot of fun outside. When you weren't exhausted, it was a great place to be. And, I lived out in the country because I knew that I needed that kind of nature fix to be able to offset the fatigue and stress of being a resident. And, we were right on the Appalachian Trail. So I would finish call and have my boots in the back of the car, and I would go for a walk out on the Appalachian Trail. And that was very healing, because, that kind of sleep deprivation really takes its toll on you. Not to mention, you're carrying the stress and worries of families. You are watching a lot of people die. We had a bone marrow transplant unit, and that's a rough place to be. Those are very sick patients. And so my colleagues were fantastic. And also that nature therapy probably saved me.
Were you? I suspect that Charlottesville was more expensive than Columbia. I had a resident that went to do a pulmonary fellowship about the time you were a resident there, and left after a year because his wife couldn't find work, and the housing was so much more expensive in Charlottesville than it was in St. Louis. Was that an issue for you at all?
Not at all. The thing about Charlottesville is it is a nice city in the middle of a county that is both phenomenally wealthy and phenomenally poor. So, I lived in a little teeny house out in the woods, out in the county, and it was, an inexpensive, lovely place to live. If you needed to live in the city, that probably would have been more expensive. But that mix in the county also gave us such a fascinating mix of patients, from people who came from extraordinary wealth to people who came from abject poverty, and the diseases that are unique to both of those echelons.
So you were a resident 4 or 5 years after the Libby Zion case, and a few years after the Internal Medicine Residency Review Committee was making its first fitful attempts to limit duty hours. Did that have any impact on you? Did the leadership at UVA, in fact, attempt to keep your workload within limits?
No, there was no
No.
attempt to keep our workload within limits. During the Christmas holiday, we were on every other. We got about 8 hours off to sleep, and then you were back on call in the ICU. Now, generally, we were on every third. You did the work that was there. There was no limit to the number of patients you could take. You took as many as the bodies came through the door and prayed at some point that you would reach capacity in the hospital. But there weren't any controls or backstops for that. I think that makes us old timers kind of curmudgeons about that, because there's a little bit of, if somebody comes in, I'm not going to hand them off during their dying process to somebody brand new because it's time for me to go get a nap. Now, probably I made mistakes because I was overly fatigued. So I know there are probably two sides to that complicated story. I think it would be really different to train now. And I bet it's a little bit shocking to them when they get into real practice to find out there's no end to your duty day. When you are a practicing physician, you do the work that needs to get done, and there isn't somebody there to come and give you a break if you've had a particularly bad day.
Yeah, it's interesting. There's a book called, I think, Hard America, Soft America, which basically posits the thesis that we keep extending, adolescence longer and longer and longer. And but eventually people have to come face to face with real life, and by and large they do and are successful at it. My own grandfather was married, had a child, and was running a farm at age 18. And I didn't have my first full-time job, really until I was an intern at age 26. So, we keep extending it. And to expand on that a little bit, as there's an enormous amount of emphasis on physician wellness now. And I will say that I was a residency director throughout the period of time when duty hours were becoming and patient limits were becoming more and more effective. And I noticed that despite that, a certain proportion of the interns would still get depressed starting around late January or early February. And some of that may be seasonal affective disorder and so on. And I came to believe that it wasn't just the workload or the sleep, it was also the ultimate responsibility with limited authority. That's a classic double bind kind of thing. Did you notice issues with mental health or wellness in your own residency cohort?
Yes, and the other thing we don't do is give people room to grieve. If you would take care of a patient for 6 weeks, you were part of their family, and when that patient died, you had a loss just as the family did. And I had patients who I would take care of over years. And I think we did a really bad job of making space for you to grieve. And that's cumulative. You have, I don't know why, but many patients who had been kind of hanging on always seem to die on my night. And my colleagues would be like, oh, good, Bridget's on call. This person's been hanging on. I'm sure that they will manage to take their last breath here. But it also meant that I spent a lot of time with grieving families. And we had no, at that time, coaching on how to deal with families who are angry or fearful or upset or have different communication styles than you do. And, everybody comes with their own baggage. So there are going to be things that bring up your coping mechanisms from your childhood and adolescence when you're under extreme strain. And my natural instinct when something bad happens is to say, I'm sorry. And one of my colleagues pulled me aside and he said, finish that statement. I am sorry you are going through this. I am sorry this bad thing happened to you. Because he said the implication is you're sorry that you did something wrong. And that was really wise advice I got from him. And I had a colleague who, when he got under extreme stress, would get really mad and confrontational, I'm sure from his younger year experience, but there was nobody ever worked to help him find a different coping mechanism. So I think in some ways we did not do a good job of helping our colleagues be good people on top of being a good physician. So hopefully we've come a long way.
Did you ever attend a patient's funeral when you were a resident?
I never had time when I was a resident,
Right.
Which in some ways made me really sad. And since we were a regional referral center, a lot of our folks came from a long ways away. So that would be a challenge. As a practicing physician, I absolutely went to patient funerals. That was important for me and for them.
Yeah, same experience, and I think for the same reasons. Attending a patient's funeral as a trainee would have just been unthinkable, because that would have meant somebody would have had to cover for you.
Yep.
And that was part of the culture that just wasn't done. So you were sort of on the maybe just a little past the leading edge of women entering medicine in large numbers, but probably because of the throughput issue, there probably weren't yet a large number of women in senior faculty positions. Did you have adequate role models and mentors?
I really, when I look back and start to list all of the people who were instrumental in my formation, there's not one woman in that group. I would be hard pressed. I had two women faculty who I spent some time with, but they were really the minority of people that I had time to spend with. I felt like we were creating in our own residency group our support group of women. And, like I said, I didn't have kids. And while I might have felt like I didn't have maybe as much encouragement as I could have from other female role models, those women who had kids, man, were they lonely. They just, I think they had a hard time. Not to mention there was that, that quiet underlying judgment of, well, you're leaving a little early to go see your kid to whatever school event. And that meant you were shirking your duties and somebody else had to pick up for you. That was real.
Interesting. What percentage of your class, your internal medicine class, was women? Do you recall?
I would say about a third were women.
Yeah. It's an interesting sociologic phenomenon. I was a resident. I began residency in 1974, and there was one woman in my class, and there was one woman in the surgical internship class the same year. And I would say that in those circumstances, the pressure is on women to socialize themselves in a way that is similar to the way the men behave, in order to fit in, and so on and so on. And my subsequent observations is that it probably takes 30, 35, maybe 40% of a residency class size being women to change the socialization metric. For the women to begin to have an impact on the residency culture as a group, it probably takes a critical mass. So, and internal medicine was a little slower to come to that than some areas, a little faster than others. And I think there are still specialties where women are in such low numbers that it's difficult to stick up without the fear of being hammered down.
Yeah.
So uh, what did you do fresh out of residency? What was your first position?
My first position was with an HMO in Pittsburgh, Pennsylvania. I went there because my boyfriend was there. And yes, always a bad move. Move for yourself, not for someone else. And it was actually a really supportive, great group to join. And it was a really collegial experience. I really liked working there, and I worked in a West Mifflin, which was a kind of a blue collar part of town, and had fantastic patients. But when you come from the outside, I think sometimes you can appreciate the cultural norms there differently than people who live inside. And so, interestingly, my patients would not go across the river, which was sort of the unofficial boundary of their neighborhood, to the big city to get something done, even though it was only an 11-minute drive. But it will, the folks that I took care of were born, lived, went to church in that neighborhood, which also meant I was an extreme outsider, and I had the world's best medical assistant. She would write me a note on the front of every patient's chart. So-and-so got a new car. This lady just had a baptism of her grandchild. This gal just broke up with her boyfriend. So I looked like a rock star when I went into the room, because she had prepped me on the social issues of that neighborhood. My stock went up amazingly once Michelle was my medical assistant. And when I ended up moving back to Independence, I wanted Michelle to come with me. And she said, but my magic is because I'm from here, and it wouldn't translate if I came to Independence. She was, of course, right. But I sure missed her.
Well, what made you go back to Independence? Long-term plan, or?
My family was here, and I missed them like crazy. So, and you spend time with Michelle, recognizing how important place is and long-term relationships outside. And I was like, yeah, I need to go back home. So I was glad to get back here. When you practice in your hometown, you get some advantages. Like, I took care of my 6th grade science teacher, and I took care of the nuns from down the street. And it was lovely to get to come back and practice here. I joined a
What job did you take when you came here?
Yeah, I joined a 4-person internal medicine group, and that was really lovely. But I realized we also don't prepare residents for that social shift when you move from the hospital to private practice. Because in the hospital, you're walking down the hall and there's the pulmonologist, and you're like, hey, I've got this question for you. I read this article. Tell me about XYZ, while you're on the elevator. You get a curbside consult, you're on your way. You forget that you're living in a walking encyclopedia. And when you're in a small private practice, everybody is going gangbusters all day. And it's in some ways really lonely and isolating to not have that enormous group of medical support standing around you. That's part of also being in a hospital versus being in a clinic. But I found that shift a little bit disconcerting.
Say a word about how you got the job. I mean, how did you identify the position? Did they recruit you? Did you recruit them? How did it work out?
I saw it in the back of New England Journal of Medicine, and called them up, and they said, come for an interview. And I did. I was like, yep, this will work. And that's about the extent of how long I put in effort to find that practice. The personalities were great. We got along well. And around that time, I met my husband on a blind date. And so my life was getting ready to change considerably. And at the same time, got recruited to start a free clinic. So there were just a group of folks who didn't have access to medical care, who were uninsured. And, I told them, I'll be involved in this for 1 year because I'm getting married and I'm not going to have time to do it after that. So I ran it for 15 years. You can see that my boundary placing wasn't very good. But that clinic was the love of my life. And as I had a baby, I decided I would step back from for-profit medicine and did the not-for-profit medicine as my full-time job. And my kids were basically raised in that clinic. And it was just really a good experience for me and for my patients.
Did it cause difficulties or hard feelings when you left your private practice?
Yes and no. The director of the practice, I think, was frustrated because I had a huge panel, and I brought a lot of clients in, so that was good for the practice. What I did was went half-time until they could transition to finding somebody to take my place. Half-time was really hard because all the patients knew that I was half-time because I had a baby. And so the lady who I answered her phone call, and she said, "Well, honey, I do think I broke my arm." And I said, "Well, when did you do that?" And she said, "Oh, I did it yesterday afternoon, but you were at home with your baby, so I didn't want to bother you." And I'm like, "Oh yeah, this is not going to work. If people are making choices about their care because I'm not here in the afternoon, that was a big clue to me that they needed a full-time doc." And that's about when I decided that it would be better for them and for me to leave practice and then do my clinic as my medicine outlet.
Wow. So were you, how much of your job was actually physically practicing medicine, and how much was running the practice?
We started one night a week and thought we would be taking care of like bumps and bruises and sprained ankles. And it became immediately apparent that people needed full-on internal medicine care. And I was like, fine, I'll do that, but I'm not going to do any mental health care. Ha! People in poverty come with so much coexisting depression and anxiety and other challenges that I went back and looked, and 40% of my patients had coexisting mental health need. So I had to get educated much more on doing a good job in that realm. But I would say my time was about 50% hands-on care and 50% administration, which meant recruiting volunteers, raising the money, doing the quality control, making partnerships, because, like I said, when we started, we were just a small operation. But by the time we ended, we were part of the UMKC School of Pharmacy service component. And we had usually 6 to 10 pharmacy students there every night. And during our daytime hours, and we brought medications in from patient assistance program. So we brought in about $3 million a year from patient assistance programs because we were willing to do diabetics, diabetic pumps, inhalers, things that were really expensive to get, but patients needed desperately. And then we had about 100 volunteers who ran the program. And, the lifespan of a volunteer is about 6 months, but the majority of our volunteers were with us for all 15 years. So they obviously found their medical home there too. Some of them in full up practice who volunteered with us, some who were semi-retired, some who were fully retired. But it was a good place to work.
So, medical training gives us no background in finance or administration. I'm sure that must have been very difficult to learn that on the fly. How did you finesse things? You sort of already alluded to, medical assistance programs and perhaps contributions in kind from the pharmacy program. How did you finesse things like, durable medical equipment and x-rays and lab tests and all those sorts of things that still cost money, even if the patients don't have insurance?
Well, the good news is I had been in private practice, which meant I had a ton of friends. And so I found out that my true talent in life is that I am a pickpocket. So I managed to snooker my local hospital into doing all of our lab work for free. And they gave us some simple x-rays. The cardiology group gave me a dozen stress tests and echoes a year. I could call any specialty who was a friend of mine, and they would work my patients into their schedule either the same day or within a week. We made a partnership with the local eye clinic because, we like 60% of our patients were diabetics because there was no one in Kansas City who was doing insulin for people without insurance. So, folks came from 100 miles around to see us. So I wrote a grant and put in a full ophthalmology suite in my clinic, and the local eye clinic staffed it. And because everybody on the team was empowered to make sure that folks got what they needed, if we had a cancellation, the secretary would be like, "Oh, you need an eye exam, go get it, and you'll get everything taken care of." And like 90% of our diabetics had an up-to-date eye exam. 100% were up to date on their Pneumovax and flu shots. 100% were up to date on their labs. So, because everybody knew what needed to get done, it wasn't just reliant on the physician. So we were team medicine long before team medicine became a vogue phenomenon. And it worked really, really well. So
it sounds like it ran on your charisma and connections, and you're the kind of person that Malcolm Gladwell has called a connector. Did the clinic survive your departure?
We spent a long time thinking about what would happen to the clinic, and it was right when the Affordable Care Act was enacted and Medicaid expansion was on the horizon. And I looked for someone who would want to take over the clinic. But like you said, so much of it was you had to be able to change the toilet paper in the bathroom and write a grant report and recruit volunteers. Replacing me was going to be tough. And I couldn't find anybody dumb enough to take my spot. And because I thought Medicaid expansion was on the horizon, I wanted my patients to be at the front of the line. So I made a deal with Truman Medical Center to take my patients, and I would give them the rest of the money I had in my bank account as sort of my transition fee for them accepting those folks. And that way they'd be right there in line for when Medicaid expansion came. The end of this story, which is 7 years later, we still were working on that. The hard part of that transition is I really wanted to make a warm handoff for my patients, because for some of them, I was the longest relationship they'd ever had. And I knew that transition was going to be really, really hard. Every patient had my email, every patient had my cell phone. I would meet them in the parking lot if they needed to pick up meds. We really, the name of our game was keep people out of the hospital. which is why the hospital wanted to give us x-rays and lab services, because they knew that we were working like crazy to keep our folks out of the hospital. And then when patients were going to go into a big system like Truman, nobody was going to call them and say, hey, I know you didn't pick up your meds. You better come, or I need to get them to you. And a lot of that, I mean, cohesive glue was going to disappear when they went into a big place. So that's why we tried hard to make sure that they were transitioning from me to someone who was going to take care of them, not just go fill out a form. But interestingly, I did a robocall to all of my patients so that they could hear from me why I was leaving, what was going to happen, what the transition was going to be like. And some of the patients disappeared instantly. As soon as they heard that we were leaving, they didn't wait to be transitioned. They just went into the wind, and that was really tough. But the ones who stuck around to help us transition did much better.
So tell me a little bit about the circumstances that led to your becoming involved with and ultimately leading the foundation.
Well, I figured out after about 3 years of doing my clinic that first, I couldn't read a spreadsheet. I knew nothing about accounting. And if I was going to do any work for the patients, I was going to have to learn more about the structure and function of medicine, because like you said, we learned nothing about how to operate a business. And yet most of us are all small business owners. Well, not now, but at the time we were all in private practice. So I went back and got my MBA to be able to learn some of those skills so I could do a better job for the clinic. And along the way, learned more about the funding and organization of medicine and the regulation of medicine. And I was hooked. But at the same time, Missouri Medicaid dropped 100,000 people off the Medicaid rolls by changing the eligibility rules. And when that happened, all of a sudden, my clinic is buried under people who no longer have care. And I realized I was going to have to get involved on the political side, the policy side, because people were making decisions about my patients who knew nothing about my patients. And so that's how I kind of got into that sphere, ended up doing some testimony down in Jefferson City, eventually ended up being placed on the Missouri Medicaid Oversight Committee, which I've served on for the last 15 years. And with all of that background, ended up interviewing for the Health Care Foundation of Greater Kansas City for their CEO position. I had already been on their board of directors. So I was on the board of directors when the foundation got formed, and then eventually came back as their CEO and was thrilled to do that. It was quite a learning curve, but just a phenomenal development experience for me. And I hope I was able to leave the world a better place for that work.
What were your challenges there? What was different about that from running? Was it just a matter of scale, or was it fundamentally different from running your being the administrator of your clinic?
At my clinic, I had a singular focus every single day. I woke up every day knowing that I needed to make the clinic work well. I needed to be able to get people to help me do that. And so, very linear goals. I ended up in charge of an $800 million foundation responsible for 6 counties with really distinctive needs, both in health and social circumstances. So the scope was enormous. It's 1.5 million people in that territory. You had very, very urban and very deeply rural communities whose needs were really different. Not to mention, people think that you're walking around with an $800 million checkbook. And so, like they say, you'll never ever pay for a meal, and you'll never have an honest conversation again when you join philanthropy. So I had both an insider's view from running a nonprofit that I think gave me some particular insight, but had to really now work on the scale of, huge institutions who wanted funding from the foundation, and a much bigger presence in both Jefferson City and Topeka. And now I'm no longer playing on the scale of, can I get somebody to give me some free x-rays? I'm playing on the scale of, can the state of Missouri change its rules around Medicaid to enroll 300,000 people? So yes, there was a difference of scale, and it was a lot of playing chess. So you need these 10 things in line to be able to get ready to do big work, both from a communication standpoint and relationship building and structural content. So you really had to be thinking about long game. And that was a lot of work and a lot of joy and a lot of headaches. But overall, it just really a fantastic experience. If I had
what do you think the single most significant accomplishment you had while you were there was?
Oh, Medicaid expansion, hands down. We watched the initiative petitions going on around the country, and realized that we had that tool in Missouri. So we pulled the team together. We got the legal analysis. We did the fiscal analysis in partnership with WashU. We really pulled both the people we thought would be against it and the people we thought would be for it together in a room, and kind of were able to write language that kept everybody on the same page. And the natural tendency is to say, well, while we're at it, we should XYZ, and to keep that group disciplined to say, we have one mission, which is to pass this, and we're going to write language that is exactly one paragraph long. And whether you love it or hate it, you're going to swim upstream with everybody else. Setting those parameters early. We also put in, the first $1.5 million to get it off the ground. And by investing that money, it let other people put their money in because they felt like it was going to be a going concern. And the latest numbers are that 315,000 people have gotten Medicaid since we put that into effect. But, there were other things that I'm really proud of. Like, we did all of the baseline work to establish community health workers, so that there were some standards and some training, and worked with the state on that so that they would begin to incorporate it, worked with different insurance companies for them to begin to think about that model as part of an extended care team. So that was fantastic. We did some of the very early clean indoor air work so that, you don't have to smell smoke when you go into a restaurant. And we did that painstakingly with every little tiny city council in our area. Raised the age to 21 for vaping products, things that maybe don't seem so important now, but at the time were kind of groundbreaking to get things set for states to make those choices and countries to make those choices. So I think we were a small pebble in a big pond with a lot of ripples. So interesting stuff.
So you've retired now from that position. What's next for you?
So I retired to take care of my dad while he passed away, and he had really a wonderful death. So that was a good choice for us and our family. And then I had a very clear plan of visiting all of the national parks. That was going to be my retirement plan. And we had made it through 30 of the 63 national parks when one of my friends died who was on the city council. And I got snookered into running for that. So now I am sitting on the City of Independence City Council as the at-large member. And that has been a new set of learning and personal growth. So I'm now 4 months into it, and I'll let you know how it goes.
You miss medicine?
Yes, every day. I mean, I miss medicine every day. But, you know, when you've been out for as long as I have, I just don't think it would be fair to go back. And, you know, one thing I'm going to chastise the House of Medicine for is we do not build on-ramps for people who've stepped aside so that they can come back in. And, you know, it's got to be cheaper to retrofit me than for a brand new physician to make it all the way through. And I think we squander some resources by not making ways for people to come back to practice medicine.
Yeah, it's interesting. When I was an intern, there was a guy that came back. His wife had been I think a State Department official in Central America. And he had not practiced medicine for some years, and then she got a federal judgeship in Massachusetts, and the residency director was importuned upon to create a kind of mini crash course for him to become a functioning physician, and he did, and it apparently worked. So I agree with you. Actually, I think that's an important thing. You have children. Have any of them gone into medicine?
Oh no, my children have not gone to medicine. I invited them. They spent lots of time at the clinic. I was hoping that I would get one, but I've got one who's going to be a commercial pilot and one who is going to probably be, I don't know, he's in political science, so maybe he'll be an ambassador, maybe he'll be the dictator of a small country. I don't know what he's going to end up doing. We'll see.
So, you know, we're coming towards the end here. If you were, and who knows, maybe this will happen. If you were suddenly asked to fill Fauci's place as Biden's healthcare advisor, what would you tell Biden to do?
Oh, I would tell Biden to focus on housing and early childhood development. I think that the preponderance of data around adverse childhood experiences shaping the cognitive and personal function is so overwhelming that if we could put our money into those first 5 years of children's life, both in financial stability, educational stability, and parental help, I think you would pay dividends that cannot be counted in the 30 to 50 to 100 years after that. But that's where I would put my money.
All right. Well, it's been a great pleasure and privilege to talk to you today. Thank you for doing this for us.
Absolutely. Thank you for asking. And thank you for being a part of American College of Physicians, such an important role of building our collegial home. So
there you go.
It's been a joy to be part of.
I didn't want this to be part of the interview because it's, you know, I don't think it's in any way incorrect to say this, but I will say that what I've observed over the years is that it must be incredibly toxic to grow up Black in America. Oh. And the reason I say that is I've had the opportunity to interact with a wide variety of Black physicians who aren't from the U.S. You know, they're from Canada or the Virgin Islands or South America or Africa, and they have a different level of self-confidence and set of self-expectations and expectation of success that is unusual in the kid that, particularly the non-wealthy, who's not part of the Black elite, doesn't summer on Martha's Vineyard, part of the you know, working class or poor Black American population that I think are severely injured by growing up in the United States in a way that doesn't seem to happen in Canada, doesn't seem to happen in Britain. It certainly doesn't seem to happen in the Caribbean. I was speaking about this with a friend, and she made the observation that perhaps in the Caribbean, at least, it's because they're in a Black majority culture where the positions of responsibility and professions and so on are all occupied by Black people. But Canada's not that way. Canada is majority white, and yet still the kids that grow up Black there seem to be substantially less injured to me. And I think it's just awful. And I think part of the unspoken resistance to Medicare expansion in most of red America is racial. No matter that it's desperately hurting their poor white constituents, probably to a greater degree in absolute numbers than the Black population. It's clearly racial. And it's just part of an ongoing series of hostility and indignities that they grow up with faced every day. And I don't know if it's fixable, honestly. I honestly don't know if it's fixable. Maybe death and evolution will take care of it, but it's huge chunks of the United States remain hugely hostile to Black Americans. So anyway,
no, I think
I appreciate you doing this. I will edit it. Go ahead.
I think you're absolutely right. And 10 years ago, I would have said I thought it was fixable. I don't know. I'm so dismayed by my country and my people in my own town. It just is, I don't know. It's distressing in ways that I'm not sure I know even how to make things better. Except to support the folks that I come into contact with and raise them up. So if you have good ideas, I'm all ears.
No, I don't. I was on the leading edge of affirmative action, and so I had kids in medical school with me. My class had 108 people, and there were 8 or 10 Black kids in it, and they ranged from children of the privileged who went to Harvard undergrad to people that were there after having bootstrapped their way up through community college and post baccalaureate programs and so on to get into medical school, and had varying levels of success. And I thought about it, and I thought that maybe the solution, which was never overtly said, was to artificially create a Black middle class, a sizable Black middle class, and that the advantage of middle classness would then create a critical mass of education and wealth and so on in the Black population that would then be self-perpetuating. I don't know if you saw the New England Journal this week. There was a thought piece by 2 Black surgeons who were disrespected within the last few months at a national conference. Now, one was mistaken for a valet, and the other one was mistaken for an audiovisual technician. They're both highly distinguished Black surgeons, but their Blackness made people assume that they were in a subordinate position. So anyway, I don't know what the answer is. Anyway, thanks so much, Bridget.